Perhaps any comments? Dr. Joosten, I know that you're the specialist, and so perhaps you have some words for us. And
yeah, so when you build
on the closed loops,
when you build an automated system, of course, it should be not too simplistic, just based, for example, on map. But the device we develop and other teams develop usually are multi-parametric. It means that it takes some other parameters like also systemic vascular resistance, delta stroke volume, heart rate, and map. In fact, in case and when we develop all these types of system, it's just not to once again replace the clinician or let them work autonomously, but it's just to help us achieve the goal we want to reach for the patient by just increasing the number of adjustment of the doses during surgery.
Okay. Thank you. No comments? No. Perhaps this is the future, but I tried in the past to work on prediction on arterial hypertension. I think there is a limit is to define a threshold of blood pressure, and I know that the device developed by Edwards and the HPA, the definition is the threshold of blood pressure below 65, and I don't know why they did this, because in my opinion 65 millimeter of mercury means nothing.
I'm not in their mind, but I mean what's been shown by Dr. A.JOOSTEN is that there's a nearly consensus that once you're reaching MAP values below 65 and 55, nearly all patients would have complications. So they maximize their signals. So it's a matter of sensitivity and specificity. So if you want to detect MAP lower than 65, you are being sensitive, because what you are triggering is not a treatment. Is you just attract the clinician's attention that your blood pressure. So one can imagine that if they had gone to 55, it would have been different, and their algorithm would be different from MAP below 75. So 65 is a reasonable choice, in my mind, because it's fairly sensitive, not oversensitive. It's fairly sensitive, and it can be accepted. Now, there are a number of publications that looked at, because they come up with a proprietary, and of course cost comes with a proprietary technology. And the issue is, can I do the same without the proprietary technology? I only look at trends. We send them, one of the articles in JAMA, I send them a letter. If I look at the trends and the decreases in the pulse pressure and the trends in heart rate, which goes up, and the pulse pressure goes down, I can do just probably as well. Except that I think it, in its goal, is attract attention that within the minutes that will follow, something is going to happen, is based on a physiological background that I accept, because when you look at all the old literature on activation of baroreflex during anesthesia and the changes that different drugs actually cause to the baroreflex activity, they haven't invented anything. You just put it into a technologically sound and fancy and proprietary and costly approach. But it's not really an innovation. Conceptually, it is not. Okay, conceptually it is not. So my question to all of you, and this should be defined, I think, by the scientific societies. There's no upper limit to complexity, sophistication. What is the lower limit under which, in rich countries, we should never go in terms of monitoring? This is the question, not the open door to fancy technology. And this would be a question that we could all address. So I express myself saying that preload dependency monitoring should be routine, as well as depth of anesthesia EEG based. And forget about the economic constraints for the moment. What would be your opinion?
Yeah, I fully agree with you. I fully agree. But reality is different.
Yes, I agree with you. we have to use more often hemodynamic device and to assess preload and vasoplasia, the vascular tone. Because I believe that when you assess the different determinants of blood pressure, you can see that in my experience, it's more often vasoplasia than real hypovolemia with modern anesthesia and technology. So I agree.
Yeah, me too, but shouldn't it be the goal of Anesthesia Society or International Society to stress what should be the basic monitor we should put for our patient? Then it should become compulsory. But
you have law, you have French law with that decide what is the basic monitor. We have heart rate, non-invasive blood pressure, SpO2. So why not for preload assessment or something else?
Yes. I fully agree with you too that monitoring stroke volume really add important information to the basic monitoring. I think that's the point that we want.
Yes, and depth of anesthesia. Even if it was not demonstrated that it decreased mortality. But so I guess that will all for today. And thank you very much for coming here. And thank you for the attending.